Dr. Wu, please.
Good noon, honorary expert. It's my pad show the patient information. Patient, 72 years old, female, chest tightness for 2 years, aggregate for 3 days, risk factor essential hypertension. Lab test result is showed normal EGFR, high BNP, normal ECG, and the normal UCG. Left ventricular ejection is 66%. We diagnose this patient is the unstable angina pectoris, current arteritis, essential hypertension. Next. The patient did the CAG 3 days ago. We see the LAO and the cranial position shows the proximal and the middle segment of the RCA is mild nasally. Next. We see the caudal position shows the distal left mid is the serous nasally. Ostium of the LED is seriously nasolian, and the proximal of LCX is serious nasolian. We also see the proximal of the OM is serious nasolian too. Next. Next, we show the LAO and the IAO cranial position. Show the LAD is serious lesion, and we see the LAD, the lesion is very diffuse and distort. Next week, according to the CAG result, we see the left mid is the distal bifurcation lesion. According to Medilab classification, it's a type 111. Also, according to the definition criteria created by Xiaoliang Chen, a single bifurcation lesion. Next. Addition, we use the syntactic score to evaluate the patient risk stratification. We see the syntactic score is not very high, and the PCI and CAG is almost effect for this patient. According to the patient's viewing, we eventually the PCI to treat this patient. Next. Our strategy is according to definition criteria and ultimate tried result created by Xiaoliang Chen. We choose the PS technique to treat the patient and guidance errors.
I think you just want to see our today's angiography. Please, I will show you our today's angio. Because the patient just performed the previous angio in the other hospital. So just because very complex anatomy of the distal left main bifurcation, so the patient just was transmitted to our hospital. Because the patient from the PPT, you can know the patient is right dominant, only mild lesion in the middle part of the ICA. We just use the 7 French transfemoral approach, 7 French guiding cast EBU 3.5. And when we engage the guiding cast, we just find the BP dumping. So that's why I use the floating wire technique just to protect the ostium of the left main. You can see the 3 wires in the distal LAD, the distal circ, and also we can call the high takeoff diagonal or the Romer's intimate, because we just use the several orbic, we just cannot show very clearly the complex anatomy of the ostium of the.
There are several questions I'm seeing here. All of them are basically directed at what is the approach you want to use for this lesion. So I'll let you answer that. What is your approach? What bifurcation technique do you want to use and why?
Okay. First, I think why I choose the transfemoral. Usually in our center or in most the Chinese center, we use the transradial bridge, and it takes part more than 95%. But for this particular case, I just said the patient is short and very thin. So that's why I chose the transfemoral approach because you can see very complex distal left bifurcation anatomy. We need more wire and also use the fighting wire to protect the 4 wires 4 rounds wires. So I think 7 French guiding test I will use it very smoothly to perform the whole case. And please show me the IO cranial. For this case, I think the most challenging part is just the big angle and the sharp lesion of the osteo-LAD. Next, please. And I can only show you that in this oblique, this projection, you can see the, the reverse angle of the LAD. For my routine performances, I like to choose the Ronsu wire because very high torqueable wire. If Ronsu fails, maybe I'd like to choose the more torqueable wire like the Sion series. So I'm very happy, and I'm also very lucky. Just use the Ronsu wire with the particular shaping, just the 2 bands, and the first band 1 millimeter, the second band 3 millimeters, and with the more than 70 degrees bending. Next, please. So next, I just check the IVUS for the both of the 3 vessels. It's LAD. So Dr. Pan, would you just give us the IVUS integrator? Thank you.
Okay, let me show the IVUS imaging. The first one, we check IVUS from the distal LAD to left main. We can see this point is the distal LAD, and the distal LAD vessel is normal. And here we can see the vessel diameter is not more than 2.0 millimeter. But the vessel, because the vessel is in muscle bridge. Then go and pull back, we can see the muscle bridge very long. And then go pull back near this side branch. Here, this is the second diagonal. Here we can see the eccentric plaque. And here is near the muscle bridge. And then pull back, we can see this vessel is normal near a big septal. So the distal narrowness is very short. And then here, this point can to do the distal landing rule. And here the vessel diameter is about 3.7 millimeter. Then go and pull back, we can see eccentric plaque. And here we can see the first diagonal we are drawing LAD. Then go and pull back. Here we can see the circumflex joining LAD. This is the ostium LAD. The ostium LAD area is about 2.4 millimeter square, and the plaque burden is about 76%. Then go and pull back. This is the POC, and this is the distal left main. The distal left main area is about 5.3 millimeter square, and the plaque burden is about 69%. Then go and pull back. This is a body left main. The body left main vessel diameter is about 4.3 millimeter. Then go and pull back. This is a proximal left main. And then here, this is the ostium left main. The ostium left main is not normal. The area is about 5.8 millimeter square, and the plaque burden is more than 66%. We measure from the distal landing rule to ostium left main, the narrowness is about 23 millimeter.
So because I think from the IVUS result, we can see the very fiber plaque.
Right.
And yeah, so I just use the cutting balloon 3.0, the Wolverine, to prepare the lesion again. I think 2.0 is not enough with big vessel. Go. Okay. It's the 3.0 Wolverine.
Okay.
Inflate 6.
Okay. So
approach
using cutting balloon here.
Okay. Yeah, right.
Okay.
Okay, done. Very focal lesion. So I just want to take a picture.
Okay.
Yeah. Okay. Seems good. Yeah. Because according to our experience, use the
How high did you go with the Wolverine there?
just use the 6 diameter 3.0 and the atmosphere with the nominal pressure.
Right.
Yeah. Because according to our Stent experience, use the cutting balloon, the modified balloon, we rarely got the plaque shift for the bifurcation lesions. So just as you see, fluid also good, right? Okay, give me the Stent.
Yeah.
So this the 3.0 by the length how 29 or 26. The Chinese domestic Stent.
Okay.
Test, please. I just want to cover the whole left mainstream. Okay.
And I think you have.
IO, yeah, IO. Routinely we use the IO cranial or LO cranial, the 2 objections to confirm our standard position.
Okay.
Okay, good.
Okay, test.
Okay, yes, test please. Thank you. So, are you happy with this? Just take a picture.
Picture?
Picture?
Okay.
Yeah, right. Picture. How do you think?
maybe a little more distal, a millimeter or two, but it looks all right. It should cover very nicely.
Okay, you want to
Yeah, I think
insert a bit more, or
yeah, a little bit more, I thought.
okay,
But
okay.
I think you're okay. You don't want to.
Test, please.
Okay.
Let's take one more puff.
Okay.
Yeah, looks all right.
Looks right. Okay. Picture again. Okay.
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 Everything looks quite all right here.
Maybe I need
A
to
little
use
more
the
spasm, I think, in the mid
spasm for
portion.
this.
Yeah. It's
But before that, I just want to use the 1x1 balloon to post dilate the left main segment. Then.
Mhm.
Yeah. Okay. Give me a 4O. 4O balloon.
Oh.
4O. Chinese.
Is this Dr.
16,
Chen's short
15.
balloon?
Okay.
Yes. Professor Chen's short balloon.
Okay.
Yeah.
The
Just designed for
pot
the
balloon, huh?
Yeah. You're right. With the
16.
no shoulder. When the play 16.
16.
16.
Okay.
Okay. Done. And with the lens 6, it's very suitable for the port.
So do you already have in China a separate fellowship for structural heart, or as part of interventional cardiology it is covered?
Yeah, right. We have. Okay. And very mature.
Dedicated for structural heart.
Yeah, right.
1 year or 2 years?
I think for structure, first, you're very sophisticated with the other interventional skills.
Right.
Like very familiar with the coronary artery intervention.
Sure.
PCIs.
Sure.
Yeah. Sometimes when you need to protect the coronary artery, so without the PCI techniques,
You cannot get into.
yeah,
You're
right.
absolutely
yeah, I agree
right.
with you.
Completely.
Okay, give me the right caudal, IO caudal, please. We just check the ostium of the two side branches. Okay, take a picture again.
I'm going to examine if there has been any plaque shift. Not, I mean,
Yeah,
the flow is very good, a slight shift, but excellent flow. I don't think
Yeah.
that should make you modify your
It's a
strategy.
question on the screen. You can answer.
So, Professor, I have a question for this case.
Uh-huh.
As you can see, just from the cranial view and the caudal view, seems like two side branches not compromised. Will you always perform the kissing or just leave it open? Because if we check the QFR or FFR, I do believe that two side branches have the more than 0.8.
Right.
So do you always perform the kissing?
Not always.
Not
always. Not always. And
any skills for this technique?
no, I think if you can have reliable FFR guidance, that always helps. I think to have a rigid strategy of having a mandatory kissing balloon is not necessarily the case, and often, as I think it may turn out to be in this case also, you may decide to leave it alone.
Okay,
But,
less is more, right?
Yeah,
Okay.
but we'll see. And so far, the flow is good.
I just use the 3.5 hyperballoon and post dilate with the 16 millimeter, nearly the rupture pressure.
Yeah.
We can see the distal stent edge have a medial dissection.
Dissection, yeah.
Yeah.
Seems like the distal part. Here, stent expands very well.
Mm-hmm.
Yeah, stent diameter is about 4.0.
Oh, okay.
Yeah.
And we cover the ostium, right?
Yeah.
Okay.
Professor, you here medial dissection.
Dissection.
Dissection is
about the medium? Involved the medium?
2 millimeter.
2 millimeters.
Yeah.
So also satisfied with the ultimate criteria, right?
So,
okay, take a picture again. Okay.
Yes, that was not angiographically apparent, and
okay, go. Okay, there's no. Oh, sorry.
Insert your.
There's no. Yes. Okay.
Okay. Okay. Okay. Okay. Okay.
Getting us to go.
Okay.
Are you also having some fellows who are training from outside the country? They come
every
here
year.
every year.
Yeah.
Very good. Very good, because With this kind of an expertise and volume, I think your center can provide so much training to students from elsewhere.
Yeah. Our
Okay.
leaders just to pay more attention for the
Sure.
younger, the junior doctors.
I think that is needed.
Okay, doctor, I will stop here.
Okay, stop.
Just please, maybe
Okay, let's
show
do
us
the
the
IVUS run.
IVUS.
Yeah.
Yeah, the IVUS.
From the distal stand edge to normal 13.
13.
Yeah.
Okay, also 35, right?
3.0
3.0
is
3.0
better.
stand.
Yeah.
So
3.0
Professor Mehta,
3
Dr.
and
just
14. 3.0 and 14.
Suggest us to add one stand for the distal part, just because the edge dissections
Right. It's
involved the
continuing.
median.
Yeah, absolutely.
Although the lens
Okay.
is less than
And
3.
probably you're looking at a 3.0, no?
Okay,
Sure.
3.0. Yeah,
Yes.
3.0.
Lens.
Okay.
Lens.
Beautiful.
Okay, sounds good.
So this is that
Just nearby the
middle segment, which
Yes, please.
Okay.
Yes, please.
Okay.
Okay, maybe a bit more, right?
Yeah,
Okay.
more.
Take
Okay.
the picture, please.
Okay.
Picture.
Okay. Wait a moment. Okay.
Okay, ready.
Okay.
Okay, take picture. So, Professor, I think here is good, right? Just
yeah, looks all right. Yeah.
Okay.
Right.
Go.
Okay.
Go.
Go.
Going up to 6,
Sixth.
6,
Okay.
8,
8.
8,
And the
10.
question is, could
10.
you even have used a
Okay.
longer one to have covered the entire mid portion also? But let's see how it looks. And once again,
10.
Going up 10, 12.
12.
Okay, done.
a
Okay.
lack
Okay,
of calcification in a bifurcation lesion is, I think, the single biggest factor which makes it easier to expand stent and have a long-term better outcomes. So far, things are looking good. You're
Looking
happy
good,
with the
yeah.
stent expansion there. I think that coverage was pretty good. What do you plan to do now?
I think just according to your recommendations, we don't need to perform the kissing, just because the from angiography, the two side branches seems good, flow is good.
And confirmed by
Yeah.
IVUS.
Yeah, right. You want to see the IVUS?
Well, I think it would be a good idea. And we have a few more minutes. I think that would be good to continue with that too.
Okay.
The beauty of MedStream 360 is the same technology is used in different methods in different countries. Those decisions are often guided clinically, often guided by economic reasons. And it is our hope that such a aggregated experience will help you make better decisions. The entire intent is to make better outcomes for patients and to use a global platform to advance interventional cardiology technique. You back to the case, the bifurcation is looking good. The circumflex ostium looks to be good. The flow in the LAD is excellent. I think that